29-year-old man with type 2 diabetes and excess alcohol intake who was admitted to the emergency department with reduced consciousness. He's on oral anti-diabetic agents, so intermediate and long-acting sulfonylureas, and we all know their side effects is that they can cause hypoglycemia for his diabetes. His friend who brought him said that he'd been drinking excessive quantities of alcohol that evening, which of the following management is not appropriate in this case. So we think that he's got hypoglycemia. He's already on diabetic agents and he's been drinking lots of alcohol. So the one thing you don't want to do for people who are hypoglycemic is make them more hypoglycemic. So in this case, it would be intramuscular glucagon. So yeah, hypoglycemia is when your blood glucose is less than 3.5. It's normally due to excessive amounts of insulin, endogenous or exogenous. It occurs with patients with diabetes who are using insulin, sulfonylureas, and rarely metformin as well. It's mainly the sulfonylureas because they can cause their side effect, their main one that you're worried about is hypoglycemia. Common symptoms of hypoglycemia include sweating, anxiety, tremor, or in severe hypoglycemia, speech difficulty, confusion, reduced consciousness, like in this man, he had reduced consciousness. When glucose values drop below the normal fasting range, the glucose meters are not accurate and the lab specimen is needed to confirm the hypoglycemia. Oral glucose drinks can be given if they're conscious and they're able to swallow. You give intravenous dextrose to those who have impaired consciousness or are in severe hypoglycemia. In patients on intermediate or long-acting insulin or long-acting sulfonylureas, there's a possibility of recurrent hypoglycemia and they should be given intravenous dextrose titrated to the blood glucose to prevent recurrence. And then given that there's a strong history of alcoholism, a CT head should be considered in this case, as alcoholism increases the risk of head injury. Glucagon may not work in alcohol-related hypoglycemia or liver disease prolonged or liver disease or prolonged hypoglycemia. So that's why we wouldn't give them glucagon. It won't work if they've taken alcohol or if they have liver disease from drinking alcohol for a long time. The other thing is as well, if they have hypoglycemia, for all of them, you need to maintain, after you give them the glucagon or the oral glucose drink or the intravenous dextrose, you want to maintain it. So if they're conscious, giving them a meal, or if they're unconscious, continuing the dextrose, continuing the IV dextrose. So over like 12 hours or 10 hours after you've corrected it, just to maintain it at a normal level. And then with patients who are alcoholics, who aren't diabetics, you'd still give them dextrose because there's a chance that they're hypoglycemic as well. So that's something to keep in mind. So the next one, you have a 55-year-old woman who presents to the emergency department with a 1 month history of shortness of breath and weakness in both lower limbs. She has a 15-pack year smoking history and has recently been diagnosed with diabetes by her GP. She has no other significant past medical history. On examination, there is reduced air entry on the left lower lung zone. Her chest x-ray shows a mass lesion on the left lower lobe. An arterial blood gas shows pH of 7.53, a PO2 of 8.6, so normal is 11 and above, and her PCO2 is 5.3. So it's usually less than 6, and her bicarb is 30.2. The blood results shows sodium is 137, that's fine. Potassium is low, 2.3. Urea is 4.8, and her creatinine is 108. The CT of the chest reveals a tumor that's invading the left lung, and a percutaneous lung biopsy confirms the diagnosis of lung cancer. What biochemical abnormalities are shown, and what's the most likely histology of the lung cancer? So just looking at her blood results and everything. So with regards to her ABG, she's got a pH, she's in alkalosis, and it sounds like it's compensated, alkalosis. So it's metabolic alkalosis in this case. It's her bicarb is 30.2 and her pH is 7.53. So it sounds like metabolic alkalosis. Because her PCO2 is normal, it's less than 6. And then the hypoxia, she's already short of breath, and she has this tumor in her lung, so that's fitting with the hypoxia, the reason that she's got hypoxia. Then you have the blood test results. You have low potassium with 2.3, so hypokalemia as well, and a CT reveals a tumor. So it feels like paraneoplastic, you know, the fact that her potassium has gone low and she has this metabolic alkalosis, it might be paraneoplastic. And the cancer, the lung cancer that can, you know, increases the chance of you getting paraneoplastic syndrome or different other features from cancer is small cell cancer. So small cell cancer has a high risk of giving you paraneoplastic syndrome or paraneoplastic symptoms. And then you have the metabolic alkalosis. So A would be the correct answer in this case. Small cell cancer, 20% of all lung cancers, it metastasizes very early and it's usually treated palliatively with chemotherapy. Patients with small cell cancer have symptoms of non-metastatic extrapulmonary manifestations, so they could get endocrine syndromes like inappropriate ADH secretion or ectopic ACTH secretion, or even EPO secretion as well, or the erythropoietin. So this patient presents with a hypokalemic metabolic alkalosis as a result of increased cortisol, which was probably because of an increased ACTH that was produced by the small cell tumor. And this may also have caused her diabetes. Hypokalemia is responsible for the myopathy and the fact that she has weakness in her lower limbs as well. Okay, next you have a 46-year-old woman who presents to the emergency department in a reduced state of consciousness. Her blood glucose level is 9. On examination, her body temperature is 33, so she's hypothermic. She has non-pitting edema on the skin of her hands, feet, and eyelids. There's no obvious head injury. She has a thyroidectomy scar on her neck. Bearing in mind the likely diagnosis, which of these is not appropriate in the initial management? Okay, so forgetting the diagnosis for just a second, if she has a reduced state of consciousness, then you wouldn't want to reduce it any further. So that immediately, lorazepam, you wouldn't want to give to a patient with, reduced state of consciousness unless they're seizing or something. But in this case, that would be inappropriate. But given her presentation, everything, it does sound like something thyroid related. So giving her parenteral triiodothyronine, that's T3, that would be okay. Hydrocortisone in case it's it's something that's autoimmune or something that responds to steroids. High flow oxygen to the patient's sinuses. She is hypothermic, she might as well be, and warm blanket as well. So mixed edema coma, rare presentation of extreme hypothyroidism. So that's probably why the hydrocortisone with mixed edema, that might help. It's a medical emergency and treatment should be initiated before confirmation of the diagnosis. Patients present with a depressed level of consciousness. They have low body temperature and sometimes they have convulsions as well. An intravenous bolus of triiodothyronine is given. Warm blankets could be used to increase the body temperature. And the thyroid failure should be assumed to be secondary to hypothalamus or pituitary disease. That's why IV hydrocortisone can be given before thyroid function tests become available. And if they have low oxygen sats, then high flow oxygen as well. Sorry, the next one, you have a 60-year-old man who presents to the emergency department with progressive breathlessness on exertion. He has a past medical history of hypertension, diabetes, and COPD. He also complained of weight loss for the last 6 months. On examination, he's alert with a respiratory rate of 25 and an oxygen sat reading of 86 on air. He has distended neck veins, facial edema, bilateral arm swelling. Which of the following management options is not appropriate initially? So straight away we're thinking, tumor, right? So requesting a chest X-ray, giving oxygen to maintain oxygen sats, yes, because his oxygen was 86. Consider percutaneous endovascular stenting, possibly after you figure out what's going on after the chest X-ray. Consider intubation, yes, definitely, especially because he has the distended neck veins, the facial edema that might be obstructing his breathing, making it worse on top of his COPD. So the one thing you wouldn't want to give straight away would be the dexamethasone, and the radiotherapy, you'd want to confirm it first. So superior vena cava syndrome, clinical condition, occurs due to obstruction of the superior vena cava. It's the most common etiology is malignancy in 65% of cases, and it's followed by benign causes like iatrogenic causes, catheters, pacemakers, fibrosis, mediastinal fibrosis after radiotherapy or after an infection, collagen vascular diseases like sarcoidosis or Beckett syndrome, and rarely you could get also mediastinal hematomas or a substernal goiter that can press on the superior vena cava, or also aortic arch aneurysm. The most common malignant cause is lung cancer, followed by lymphoma and metastatic breast cancer or colon cancer. And the patients come in with shortness of breath, cough, facial plethora, edema, edema of the upper extremities, distended neck veins and chest veins, and in severe cases, they also have stridor that's related to laryngeal edema or direct compression. And then oxygen, you need to give them oxygen to correct the hypoxemia. In this case, the SATs were 86%. High flow oxygen was a good idea. And also a chest x-ray to show, the causes, whether it's a widened mediastinum or a mass lesion, so this is directly pressing on the 𝕊𝕆ℇ𝕀𝔸𝕃. Airway management is important, as the patient may have upper airway obstruction and because of the severe edema, so intubation should be considered. And steroids and radiation therapy or percutaneous stenting are for the relief of the obstructive symptoms. Urgent combination therapy with radiotherapy and corticosteroids are only used in life-threatening cases, as they may cause interference with subsequent diagnosis. So in this case, he hasn't even been diagnosed. So giving him dexamethasone might shrink the tumor, and then with regards to histopathology, you might not be able to find the diagnosis if you've already given them steroids and radiotherapy. So it'd be after the diagnosis. Okay, in the next case, you have a 25-year-old female student who's normally fit and well, who presents to the emergency department 3 weeks before her final exams. She's drowsy and confused. On examination, she has a hepatic flap and is jaundiced. There's also tender hepatomegaly. Which of the following is a pertinent first-line investigation? So 25-year-old, normally fit and well, and she comes into the emergency department 3 weeks before her final exams. She's drowsy and confused, and she has a hepatic flap and is jaundiced. So hepatic flap and jaundice, and she has tender hepatomegaly, that could be because of alcohol, or it could be because of paracetamol or a hepatitis screen, but it was very acute, so it doesn't make sense to be the hepatitis screen. So it's just between, the gamma-glutamyl transferase levels and the paracetamol levels. Given her young age and the fact that they didn't even mention alcohol, I'll just go with paracetamol levels. She has exams coming up, and it just fits the picture of the student. So the patient's most likely to have taken an overdose of paracetamol, resulted in the features of acute liver failure that are demonstrated above. So you can get the same picture with alcohol, but in the long term, but not in an acute setting as well. Oh, so that's another good way of ruling out the GGT. And for alcohol, it would happen over the long run. It wouldn't happen very acutely. It would be someone who's been constantly drinking alcohol. Paracetamol overdose in the first 24 hours presents with non-specific symptoms with nausea, vomiting. You can get hepatic necrosis 24 hours after the overdose with the classical signs of acute liver failure, like in this patient with the hepatic flap and the jaundice and the tender hepatomegaly. Initial investigations would include the liver function test, the paracetamol and the salicylate levels, and the blood glucose as well, because they're prone to becoming hypoglycemic. You'd also want to do the urea and electrolytes. They might develop hepatorenal syndrome, and so the urea might be increased, or it might not be because it's synthesized in the liver. And then you also have clotting and ABG, clotting factors for the liver, and ABG to look for lactic acidosis. If patients with a paracetamol overdose present within an hour of ingesting the paracetamol, you can actually give them activated charcoal to prevent the absorption. But if they come within 4 hours, then you do a paracetamol level to determine if they need the N-acetylcysteine or not. But usually it's within 8 hours, they gain the maximum protection with the N-acetyl, with the NAC, the N-acetylcysteine.